Hello, everyone, and welcome to the anchor session of CME Palooza Spring. I am Scott Kober, one of the co-producers of CME Palooza, and I would like to welcome you to our 1 p.m. Eastern Time session entitled Elevating Our Educators, Practical Strategies for Improving Faculty Teaching Skills. This session is being moderated by Alex Howson. Alex is the president of Thistle Auditorial. So this is going to be one of our interactive sessions. For folks who want to be a part of this presentation, certainly I will encourage you, if you do not have not already done so, if you can either download the Poll Everywhere app in the App Store or on Google Play. And then once you open the app, enter in CME Palooza in the Join Presentation box. Or you can open a web browser and go to the URL here, www.pollev.com/CME Palooza. We have a few questions that we'll be asking here at the beginning of the session, and then throughout the session, kind of early on, to kind of gauge some of our audience's thoughts towards some of the topics that we're speaking about. So before we begin, as with all of our sessions, I want to acknowledge the sponsors who provide support to CME Palooza. Our gold sponsors, Genentech and ACHL. Our silver sponsors, ASIM, Forefront Collaborative, Educational Measures, Medscape Education, and Peer Audience. And our many bronze sponsors, Catamount Medical Education, Clinical Care Options, CMEology, Creative Educational Concepts, Global Education Group, Helio.com Education Lab, Impact Education, Infograph Ed, PrimeEd, Primary Care Network, Real CME, RedMed Ed, RMEI, Viator Medical Communications, and Vindico Medical Education. So there are 3 ways to ask questions during this and all the CME Palooza sessions. You can use the Educational Measures text line to send in a question. The number is 267-666-0CME. You can click on the Google Slides link that is found on the live page. So click on the one for the Scott session. So the URL is here, but you can find it on the live page. Or you can tweet your question to us using the CME Palooza hashtag. And so before I transition it over, we've got a couple of initial questions that we are going to be asking using our Poll Everywhere software. So here is our first question. So how much work have you gotten done in the last 2 days? A lot? You guys are just background noise? A little, bouncing back and forth between work and sessions? Or none, all CME Palooza all the time? So ladies, what are your thoughts? How much of these sessions have you actually been able to catch during the last 2 days? Alex, you want to offer your thoughts first?
Not as much as I'd like, but I archive things, so I know I'm going to get to sessions eventually. Okay.
All right. So it looks like most people sort of bounce back and forth. So at least we're not background noise for a lot of people, which is good. Okay. So we have our second question. In one word, how would you describe CME Palooza? Eve, do you want to give your thoughts first?
Always enlightening. Oh, well, that's 2 words.
That's 2 words.
Enlightening.
Enlightening. Eileen, any thoughts?
Yeah, I would say fun.
Fun.
I enjoy the kind of the vibe of CME Palooza a lot.
Okay. One word, not multiple words. Sorry. Robin?
Educational.
Educational. Okay, so we have informative. We have, I believe this is we have Palooza-rific, something like that.
I like that one.
And we have Scott for president. That's no one actually submitted that one. Okay, so thank you for those of you who answered those questions. We've got a couple more questions that will be coming in here in a minute. But to get this session started, first our speaker disclosure slides. So just be mindful that the opinions, discussions, and/or conclusions expressed are those of our panelists and do not represent an endorsement by or position of their employer, parent company, or affiliates. And so with that, I am going to turn things over to Alex Howson to introduce the session and to introduce our panel. So Alex, go ahead, take it away.
Thank you. And first of all, what a lot of sponsors. That's terrific. Well, thanks for joining us on the last session of Spring 2018 CME Palooza. As CME CPD practitioners, we work with faculty a lot. They provide their expertise to help develop content and also present some of that content in live and online formats. But we've been thinking, their deep clinical expertise doesn't always equip faculty to educate adult learners. The Latin origin of the word doctor is actually docio or docio, depending on who taught you Latin. And that actually means I teach. But lots of physicians and clinicians, although they're experts in what they teach, very few have actually had any training on how to teach. So this conundrum is shifting a little bit. Certainly medical schools and academic centers in the US, as well as Canada and the UK, are starting to really think about how to prepare faculty to be effective educators. And it's something that's on our mind in CME CPD as well. So this session explores best practices and strategies for supporting faculty to be effective educators. And this panel is comprised of Robin Snyder, who is Director of Education Design at the American College of Cardiology. Oh, thanks, Scott. Yeah, I forgot to say. Next slide, please. We also have Eve Wilson, who is Medical Director at the France Foundation, and Eileen Kotelny, who is Director of Educational Development, also at the France Foundation. Can we have the next slide, please? We also have a question. We want to kind of kick off this session by asking you to just take a moment to think about and describe a challenge that you may have had in supporting faculty to be effective educators in the context of CME and CPD. So we'll just take a moment. And while you are kind of thinking about a particular challenge, we'll explore some context around this whole business of supporting faculty. So I want to ask Robin first to talk a little bit about the rationale for CME's role in supporting faculty to be effective educators. What is that rationale, and what are some of your best practices in supporting faculty to be effective in what we're asking them to do?
Absolutely. So I think, one of the things that certainly, Alex, Eve, Eileen, and myself have spent a lot of talking about is that this is really a topic near and dear to all of our hearts, and a topic that we all have opportunity to really, no matter the size of our organization, really engage around and to help our faculty to be better educators. And certainly the environment we're all working in today, really lends itself to doing more and more to help our faculty to be able to be effective in teaching different types of, in different types of settings, really helping them to be able to help deliver on different types of educational formats. So think about everything that's happening around the, loosening up of education formats that we can certify. So with the work that the AMA and the ACCME have been doing, there's certainly a lot of opportunity that also exists. And we're being pressed, right, to deliver on outcomes through the new commendation criteria that have come out through the ACCME. So, those things are really helping to press us to be able to be as effective as possible in, delivering quality education that really, moves the needle in terms of learning. And I think the thing is that we certainly face here is that our educators are, they're really hungry right now to learn about learning science, and they're really hungry to understand how to be able to ensure that they're delivering quality education. So I think in our session today, we certainly hope to be able to look at some of the behaviors we all run into in working with faculty, whether in the live setting or in working with them to deliver online education, and to give you some of our tips and strategies that, we've found to be effective in really then helping to kind of move beyond those behaviors and helping them deliver effective education.
I'm really interested looking at these comments from members of the audience, especially that second one, I'm intimidated by them, because I think this is something we don't really talk about very often, even those of us who've maybe been through the kind of academic mill ourselves, and even people who have medical backgrounds, perhaps have been to medical school but not necessarily practicing medicine. Do you guys want to, before we kind of move on, respond to some of these comments? They're fascinating. And we were going to talk about some of them, but this is an opportunity just to kind of, for an immediate response.
Yeah, I'd love to just address really quickly the one, I am intimidated by them. I think it is really a challenge a lot of us face because we are not subject matter experts when it comes to the clinical content. But I think what we all have to remember is that we are still experts in what we do, that we have spent a lot of time on our own professional development, understanding key principles and ideas that help make for effective education. And so I think what we have to do is acknowledge their subject matter expertise and really look at it from the perspective of how do we help deliver our expertise in partnership with them. And so it's okay not to be a subject matter expertise.
Yeah, I agree with that, Robin. And I always, I'm always talking to my mom and she's like, how do you do that? Like, how do you talk to, well, like I always look at my role as being somebody who helps these subject matter experts organize their expertise, right? And so the power of asking questions of their expertise is a great kind of way, because often they'll jump past a key teaching point or learning point for their audience because they are so deep in their expertise. And so helping them kind of break their own content down can be something that being inquisitive, being curious, being open, asking them questions can actually help them build out their content in a little bit of a different way. And I think it also plays into their confidence. And that's always a nice way to kind of make friends, I guess, with someone that you're working with. So that's definitely, because I absolutely understand that second comment.
I could speak to perhaps the first comment. My providers are the experts. They don't need educational coaching, or I've been educating for years. I'm confident in my teaching methods. We do hear this. What I think this requires, and we'll talk more about this, is having your faculty know up front what's expected from them. So if, for example, coaching is a required part of participation in the development of the activity, they need to know that up front, and that it's really not an option. And that's what I try to do, in, of course, a professional and very nice way. And then I think what happens is often when we do these kind of coaching sessions, they're with groups, and I hate to use the word behave themselves, but they will behave themselves in a situation with their peers. And I think they frequently find that they learn something from it, and they get to take away something they didn't know they would. Not that they may admit that, but I think I've seen that happen.
So Eve, you actually use the term coaching, and I know, Robin, this is something you've talked about as well, and one of the comments actually uses the term coaching. What should we be thinking about in terms of a philosophy of faculty support? How important is the terminology that we're using in coaching, mentoring, training, supporting? Do these things, do these terms have different meanings in terms of overall support for faculty?
Yeah, I do think, one of the things we have to remember is, particularly in academic medicine, some of these terms have particular meanings that may be different to us, those of us who aren't in academic medicine. So I think in academic medicine, certainly mentorship has some very specific connotations as to what that means, versus, coaching even, or supporting. And so I think some of the terminology comes down to knowing your particular group or audience. And I think we really like to think about it in terms of we are supporting our members who are content experts to be also expert in delivering on whatever educational format we might be asking them to teach within. So I do think words matter, and some of it is you have to know your audience and choose your words in a way that's going to resonate with them and engage them in the conversation around this partnership with them.
I also think it's probably better to, if you're in a situation where you're trying to give faculty input on teaching skills, it's probably better to call it coaching than training. And it's certainly not mentorship, but I think the idea of faculty training kind of puts people off.
No, that's an interesting point. We might circle back around to that. Eve, you talked about faculty behaving themselves. Scott, could we move to the next slide? Because one of the scenarios that I'm sure a lot of us are familiar with is one that we've described as hijacking. The one after that, I'm sorry, we're behind in our slides already, or ahead of our slides already. That's good news. Yeah, so we
this one?
Yeah, the one with the little skull and crossbones. We've thought about one scenario which we've described as hijacking. In fact, there was quite the extensive discussion thread about this a few weeks ago on the MEC discussion, the Alliance MEC discussion thread, along the lines of, your planning committee has a well-researched needs assessment, a content agenda, objectives, and a reasonable expectation of the measurable expected changes for the activity. You get on the initial call with faculty, and the faculty member hijacks the process with negative feedback. So we have another polling question for you along these lines, in which during a faculty call that includes a CME activity with a problem-based learning component, one of them states outright that they've never had PBLs work well. How would you obtain this person's buy-in and get the planning back on track? And just in a few seconds, I think Eve's going to share some of her strategies for getting faculty to behave. Can I say that?
Do you want me to go ahead?
Yeah, how do you, I guess the wider question is, how do you find faculty to be effective educators who are true teachers? I think is a term that you've used quite a bit.
And what's I like to use.
Yeah, and what's your approach to getting faculty who hijack a planning call at the outset?
Well, I like to avoid this situation to begin with. It still happens, but if you're a careful planner, and I have the luxury of having wonderful program managers at the France Foundation. Shout out to all of them, who are get these people on board and get them up to speed on what's expected of them. If that goes well, this shouldn't happen. The other part is that if you have, well, let's back up a little bit. This situation it's not a real situation. It's one I sort of made up that was cobbled together from several similar situations. So it does happen. Someone just gets on, maybe they haven't read their email that, it was said that there will be a PBL or a problem-based learning component. And so I think it's just really important to be assertive. Just say, well, we don't have a choice about changing the format at this point. Then if you've planned well and you've got hopefully this isn't your chair of your faculty, you can get your faculty chairman to come in and say, well, this is how this works, and let me explain it, and let him be your champion, because they're going to so much more, that it came up the issue of being intimidated. I've been doing this probably too many years to be that intimidated, but at the same time, I understand that they're going to listen, our faculty are going to listen more to their peers than they are to me. And I understand that, and I don't take it personally, and hopefully you have a chair who will speak up about the value of the problem-based learning and why it's being used, and yes, that it will be used and it will work well. I will say that sometimes these folks, we have to understand that they've had a bad experience. They may have been sent into a situation where they were told to run breakouts and had case studies on but there was no one there to help them facilitate that, and they had no prior knowledge of how to do it. So that again goes back to planning. It goes back to having them know in advance what is specifically expected of them, and have them buy into that as part of agreeing to serve as faculty for that activity.
Yeah, Eve, I think you've hit on an important piece, because I think a lot of times the objections that we hear from faculty, they might feel like they're objecting to the value of the design component, when really, when you get down to it, it might have something more to do with their own comfort with it, what mood they're in. Those are the types of things that if you talk about the support that you're going to provide, how you've seen it work in others, and to not let it derail the call. I think the comment there of, talking to them offline, finding a way to kind of quickly pivot away from that, but not always, assuming that it really is about the value that they see. It might actually be hidden more in their own sense of ability to do it or comfort with something different.
I was just going to chime in as well that sometimes we have to be careful of the words that we use too, because sometimes they don't know exactly what we mean when we use certain words. And sometimes I think I've also run into, I wonder if the objection is more, they also don't, they have pride in there as well, and don't want to admit that they may not quite understand what it is we mean when we ask them to do something. So making sure you give people examples, as we've alluded to, or give them ahead of time, like a definition of what a particular format is, or an example of what that's looked like, often goes a long way, and also helping to try to head things off. And I think that's sort of the theme you're hearing, is trying to mitigate on the front end is always a great strategy.
And building back a little bit on, but what both of you have said, but also what Eileen was saying, I think if your activity is carefully constructed to sort of, I mean, a lot of what we do now has got multiple components, right, of designed to promote interactivity and all kinds of things. And as long as they're pulled together in the correct way, in a way, this makes the faculty's job easier, not harder. And I think that's a kind of a way to sell that to them.
No, I think that's a great point. Scott, did we get any comments from the audience on that second polling question? I don't want to.
Yeah, so there's a couple of them that I'm showing up on the screen. I don't know how well you guys can read these, so I can read them up to you. So know up front how you were going to address these questions. This is very common, so it should be dealt with proactively. Talk to them. I presume that means the problem faculty offline, and try to keep the call on track. And another one says send them evidence. I can send them evidence that this approach works.
Right. Yeah, that's a good point. And that relates back to one of the comments that somebody made in response to the very first polling question, though, about we're reading the educational literature, not faculty. So if we're able to kind of share pointers that helps to supply that evidence base, then that's a further potentially effective strategy. So we've talked about the rationale for supporting faculty to be effective educators, and we talked about one specific scenario and strategies to provide a kind of course correction. Eileen, let's turn to some approaches to optimizing faculty input into education activities. You've got the buy-in, you've had the planning call, you've had the communication, you've got somebody on board. But now what can you do to make sure that the content that they help to shape or that we're asking them to present actually adheres to adult learning principles?
Yeah, so when we were thinking through kind of common scenarios that we've run into, and I think I saw in the first polling question somebody talking about they have so many slides, and so I think about this is kind of the cognitive overloader, right? They have so much. Maybe this is a deck that they've had for years and years, and they're adding to it, and I can do 90 slides in 30 minutes. That, we've all kind of encountered this, right?
Yeah.
So, and this is purely in kind of when we think about the live setting, that helping faculty craft their content for online is a whole nother ballgame, but it kind of plays into the same thing, right? How you segment content into smaller pieces that learners are going to be able to better absorb. That's ultimately what you're doing, whether it's a 30-minute presentation from a podium, or if it is a short piece online. You're really trying to help them break it apart and find natural points at which to transition the learner. Mm-hmm. So some of the things, when I've seen it successfully done is thinking about how to break apart that content. So your learning objectives being nice, natural ways to organize, right? So you can always come back to those. I think sometimes, how they structure a presentation or a set of content, tell them what you're going to talk about it, and then remind them of what you've talked about. Like that basic organizational principle, sometimes faculty, this is missed, right? So even just some basic organizational techniques about how to put together their slides can go a long way, especially if you have this openness.
And if I could add to that, in my role at France Foundation, it's actually my job to work through slides with faculty. And for example, if they send me 100 slides and say they can do it in an hour, I'm going to be doing some slash and burn. But I think that what's, and not in a rude or overbearing way, but to help them get to the core of what it is that we want from them, how to meet the learning objectives. I think it's a great idea. I think of the learning objectives as a broad outline for the talk. And I think you always want to remember, and people hear me say this a lot, that you want to tell a story. Even when it's a presentation, a clinical presentation, it's always a story. There's always a beginning, a middle, and an end. If you have cases there, your plots and your subplots. And I like to think of it that way, and I like to get them to think of that way, because there should be a natural flow, as Eileen mentioned. And I think that really helps get through the crap. Can I say that? To cut to the point of what is going to be what's going to be in the end a nice, cohesive, and valuable presentation that leaves people with something that people can take away learnings from.
Well, and I think Eve, your kind of clinical and medical director expertise, like your ability to go through and slash it and organize it for them, is awesome. For me, not having that clinical background, I rely on either clinical colleagues like you, or on that subject matter expert to help me understand how to package different pieces of it. And that's where kind of what I was talking about before of asking questions. Does everybody understand this concept? Is there something here that's kind of the future versus the nuts and bolts, which this presentation is supposed to cover, helping them identify what can get moved to the side.
Absolutely.
So we have a question that came in over the educational measures text line that I'll chime in for. So the question is, how many of these issues can be avoided with the selection of faculty who are open to novel educational concepts?
Well, can I answer that? Because I absolutely think that is, I started to get at it earlier on. It's all about planning. It's all about picking the right people. And we actually have, as part of this presentation, it's at the end of the presentation, not intended to really be part of the presentation, a list of sort of tips for faculty selection. And I agree. It's like we had said before, you need to know up front. The faculty need to know what's expected of them, and they need to know what the components of the talk are going to be. So that will help you avoid a lot of pain. I guess that's what I'm saying. I don't know if we want to flip to that list, Scott. It's on the. We have uploaded it to.
Here we go. I think it's the very last slide.
The very last slide.
Yeah.
This is a little hard to read, but I also there's also going to be a version of it that's uploaded to the CME Palooza website.
One after that.
That's it. So these are not the end all to be all, but it's a list that I use when I'm teaching medical writers about faculty selection at the American Medical Writers Association. I do a workshop for them each year. And they range from, what their appointment is to being open to innovative and interactive formats, which is, and at the last one is someone who's reasonable to work with, which is always nice. But it's true, you really don't know this until you've worked with people. And we have ourselves sort of a group of people who are our go-to. You have to be careful about that because you don't want to have the same faculty all the time. But the better you know them, obviously the better that it's going to go. So that'll be up on the list will be up on the CME Palooza website and there for your access.
I have a question. I think both you, Eve, and Eileen talked about, and maybe you did too, Robin, about stories and about telling stories. And of course, this is something that we hear in many, many parts of professional life. The power of the story. We're wired for story. People understand stories as a kind of format for presenting information and as a teaching tool. But I'm kind of wondering what the hesitation is amongst a lot of faculty to use stories, because it does seem that that's often a piece that is missing. Is that something that's part of your experience or the audience's experience, that, we have this emphasis on stories, but actually telling a story is pretty darn tough?
Well, I think a lot of what we do here, right, is, again, I think some of this is what are the words we use and how do we communicate that to faculty? Because in their case, they tell stories all the time. They're cases, right? Yeah. And so that's why case-based presentations are so powerful when they're well aligned to whatever the key teaching point is, because every clinician, they think in cases, they remember cases. So again, I think it's translating some of our verbiage about storytelling into the framework that makes sense to them, and talk about, what is it you're really trying to communicate to your learner? What is the one thing you want to make sure they walk away with? And so how do you frame that up for them? And how do you communicate that in different ways? And one of the ways is to talk about a case, tell a story, to help really illuminate the point you're trying to make. And we find when we talk about it that way with faculty, it resonates with them. Mm-hmm.
And I think this might be something you wanted to get at, Eileen, and we can probably move to the next slide, because I'm pretty sure we've all had the experience of working with faculty where they really want to focus on the clinical data, they really want to focus on the evidence. They have cases, but they're still not quite able to kind of present those cases as something that people want to listen to. Do you want to just kind of respond to that?
Yeah. When we were thinking about these different kind of faculty archetypes almost, the just the facts, ma'am, people or faculty that are much more comfortable talking in data and evidence and the facts, and to color it, to use things like stories or cases, as Robin very smartly points out, the use of analogies. Sometimes, the most complex concept can be explained in a way that really sticks by making it completely outside of the clinical space. And it's an analogy that is perfect, but not what you would have thought of. And that sticks for learners. And so I think that it's helping faculty maybe see those opportunities. Even if this is new evidence coming out and you're anchoring it into a case that suddenly the diagnosis or the treatment has changed because in the new evidence, that is a really effective way for learners to say, oh, I just would have totally blown that if this were my patient. And so I think it's helping them see those opportunities within the content that they have, and recognizing that for some, this is not an easy skill to do. So helping, that's where the emotional intelligence of the work that we do comes in, is to figure out how to have those conversations and help them see it. If you recognize that this is a faculty who likes to to live in the charts and the graphs, you know?
Right. Right.
And again, I think some of it is building in the tools, building the tools into the presentation, helping them find where you can ask a question of the audience, for example, how you can use that as I like to think of it as a plot device to move the story along.
Right.
So I think that it's getting them out of their comfort zone, but it's also helping them to see it's not that hard. In fact, we give them the tools, it makes their job easier and not harder. They're not standing up there and having to present just the data. They're putting it in context in a way that's natural for them and natural for the audience.
And talking of audience, I think we have another question.
Yeah, so there's another question from the educational measures text line. So it's kind of, I'm not sure where this quite fits in your discussion, but I thought it's a good question. So any thoughts on the differences between coaching patients who are part of a live educational program as a presenting faculty member?
Open to the panel.
That's a very good question.
It is a good question.
I mean, I think I heard about, at the workshop that the ACCME hosted last week, talking about this, about, making sure that patients feel empowered and depending on who that patient is, right? If they are a well-versed patient advocate, they're very used to sitting potentially up on a panel with different folks, doctors and different folks. But if they're not, then figuring out how to structure the conversation in a way that makes them feel comfortable. I think that's a very good question.
It's interesting. One of the strategies too you can use, and I think this builds off what Eileen is saying, is that it may be a matter of then setting them up with a clinician, getting those folks together ahead of time to have a conversation and build a little bit of rapport, because that's going to really put the patient at ease and turning it into a conversation between the clinician and the patient. So I think it is situationally dependent. And I think Eileen makes a good point. There are certain patient advocates, they speak in front of clinicians all the time, and they're very powerful in the same strategies we're talking about using with our clinicians are going to be just as impactful, just as useful to them. And so I think it's just knowing that, but thinking creatively about, who's the audience again, and how do you put everyone at ease and really make sure you're going to, in doing that, still get your teaching point across. So knowing why you have that patient there and what it is you really want them to be able to communicate to the learners in the audience.
And I think, too, what you may want to do in that situation is have a little bit of light scripting, maybe not, a list of questions that the faculty will read from, but have developed in advance more or less the flow of what the conversation will go like. It depends on what you're using it for. Obviously, if it's a live meeting, there's a lot more pressure on you to kind of get a point across, as opposed to we recently did we use patient actors, but we developed scripts, and then we actually had the physician involved, basically tear a script apart, because he would say, well, I would never say anything like that, so to make it more natural, but that could be a way to do it.
And I think another way to go is, we saw at the Alliance meeting in January, patient Dave and his physician, they have a pre-established relationship. And I'm certainly seeing that a little bit more, where faculty themselves are suggesting patients to be involved in educational activities because they have, they've treated them, or they know them through some other kind of, patient advocacy group, or so that relationship is already established to some extent, and that can certainly be helpful. And
the power of the facilitator too,
right?
Yeah, like having facilitators, whether it's a chair or, really sensitive to that. I mean, you have situations sometimes where patients coming in who've been diagnosed in the last week, right, with a thyroid nodule, and that is a very scary place for them to be personally. And then, so the more kind of stewardship that physicians kind of leading the activity can have with the patient, I think is helpful.
Yeah, absolutely. We have a little bit of time, and I know that a couple of you kind of touched on, you said words like curriculum. So, we've been talking mostly about preparing, supporting, coaching faculty in the context of perhaps a single or a series of CME activities. And I did mention at the beginning of the presentation that certainly the whole business of faculty development and preparation for teaching is something that probably the UK and Canada are further ahead on, but the US is certainly beginning to really grapple with that wider issue. What's the role of the CME community in a broader curriculum approach to supporting faculty over time?
Yeah, so I think it really is. It is. We need to think of that as part of our role. And I would go back to the idea that, you know, for each of us, it's really something everyone can do. You don't have to have a large curriculum developed, but you can coach faculty on an individual activity basis. You can use all of your knowledge and expertise and the tips and tricks we've talked about to be able to make an impact with your faculty. And that doesn't matter if it's a face-to-face activity or if it's even working with faculty who are delivering in the online space. So we haven't spent a lot of time maybe as focused on that, but I think recognizing these same principles hold true across both the live or face-to-face setting and also in our online spaces. So I think that's important to keep in mind.
Yeah, it really strikes me that, you know, it's something that we are all doing, all struggling with to some degree, right? And depending on the type of CME provider you are, it might look very different. So yeah.
Oh, sure.
Yeah, and that has its own set of challenges. I know, you know, with the specialty groups, creating an educational, you know, a home for the clinician educator can be really effective, whether, you know, it's having particular programming at annual meetings, let's say, that is focused on helping them be more effective educators when they head back home. Like that can be a very empowering feeling. If you can find even just, you know, a few sessions at the annual meeting and create a little track for the educators, that can bring value from the specialty society, from the association of their work. So I know a lot of folks do that. You know, Robin, you over at ACC, certainly. So
and I think at some of the academic medical centers are doing that, and they have the advantage of sort of being able to either require that their faculty do these sort of training to be a better educator kinds of programs, or they have ways to, you know, incentivize it. It's part of career development, or I think getting faculty to agree to participate in these is sometimes a challenge. So you may have to come up with incentives or persuade them of the value of it. Some will automatically come because that's what they want to do and that's how they see themselves.
And I have noticed, I was just going to say, I have noticed that younger faculty are more, you know,
it's probably coming out of
faculty who have trained more recently are certainly more switched on to kind of education innovation and the need to think about that. I think we have another question, Scott.
Yeah, another question came in. So how often, if ever, do you have faculty ask for a critique of their presentation or their presentation style? And if they do ask, how honest are you with them?
Anyone?
So I will say we do have that happen, and we've really evolved part of our model to offer faculty coaching at our annual meeting and in that setting. And so one of the things, though, that we've been able to do is we also have a course that we run that really is a faculty development course, and we've used graduates of that to then be the folks who then go and critique their, you know, so it's a peer-to-peer then interaction versus, you know, a staff person providing that, you know, but there, again, a lot of folks, if they've asked for it, you know, they want to be better. So I think we're all in a position that we all know how to be, as Eileen said earlier, use our own emotional intelligence to think about how to couch things in a way people will be willing to hear them. But you do need to be honest with them if they're wanting to improve. But I think it's also then being prepared to give them strategies and give them tips in terms of how to make that improvement. So, what might you be able to do then to offer them some ongoing support and advice to, make that transition that they're hoping to make to be a more effective educator. But again, using their peers and is always, a great way to try to get that input and have that heard.
Well, and really what a great learning experience for them as learners is to then turn around and evaluate some of their colleagues at the next meeting that they're at and think about these strategies that you might have pointed out. And why, as a CME community, I think, frame that, like that's CME, right? Like this teaching. And we see with the new commendation criteria, it's all over the place about this type of work. And so I think there's value to us in a lot of different ways, to our faculty certainly, and to us as CME providers, to be able to structure these as formal educational interventions that are layered over the work that they're already doing. So it doesn't have to be something where they have to do something extra. Maybe you're working on an online, activity with them, and at various points, you're giving them feedback about the contributions they're making to the educational design conversations or something like that. Like there's a way to structure it as an individualized learning activity for them as faculty.
And it can be informal. It doesn't have to be part of formal.
Right. And I think the other key piece that's come through that I see coming through that is that it does need to be peer-to-peer, colleague to colleague. It's not going to be me, the CME provider, telling them what feedback they've gotten. It needs to be from either, again, we could go back to the chair sharing the information or something like that. So it's peer-to-peer.
Right.
I think the other thing is sometimes where we have to remember that clinicians are used to receiving feedback all the time. That is the nature of what they do. And sometimes I think we're a little more reticent or hesitant to share that input with them than we need to be. This is a environment they live in and day out. This is how they've gotten better at their craft, is by getting feedback, and they really are much more open to it sometimes than I think we may give them credit for.
And that probably takes us back to the intimidation piece, which reminded me that I was a trauma operating room nurse for a long time. And there was a big Irish surgeon who, when he got cross, he just used to throw his instruments across. Oh my goodness. So that's intimidation, folks. Right. I think we have another question.
So this is sort of a follow-up to that previous question. So it says, I love that last question, but the ones that ask that are usually awesome presenters or at least very aware of the need to improve. What about the ones that aren't asking for feedback? How do you give them feedback in a way that is encouraging yet constructive?
I like to use learner feedback. So learners, we ask for a lot of evaluation feedback and that's very non-confrontational, right? It's just objective data from a learner perspective. So sometimes if you have that, that's a great way to open the conversation and to acknowledge with them, I know that you want to, we'd like to continue using you as a faculty member. We, recognize that you want to be as effective as possible. We wanted to make sure we shared these comments. And then again, it's offering support, I think, on the flip side. And that can come in many different ways. And, some of it is you have to know, is that person going to be open to hearing that from you? Do you, as we've suggested previously, need to use another member of the faculty or a chair or a member? In my case, we have opportunity to use members who are part of some of our committee structure because I'm in a medical specialty society. So I may have more options, but I think we're doing a disservice to everyone if we don't at least really try to find some ways to make sure that we're just very honestly and objectively sharing some of the information and trying to help then support them.
I think that if you're using learner feedback, that
Yeah.
wrote down in there she uses her hands too much or something like that. And it was funny to me. And when I spoke to, when I was getting the feedback from American Medical Writers, they said, oh, we call that the outlier. So you may not want to share all of the information that you have from your evaluations. You may want to be a little selective so that you can be constructive and encouraging.
So we're kind of coming up to 10 minutes from the top of the hour. Are there any, and I think we've covered quite a lot of ground, are there any other points from the panel that you want to make before we kind of wrap up, or any other questions from the audience?
There are no questions from the audience, so if you have final thoughts that you guys all want to share at all, feel free to do so, or if not, I can wrap it up.
Well, just
all right.
I was just going to very quickly summarize, because we talked about a lot of the points that were on the previous slide in terms of setting clear expectations. What does that mean? It's important in planning any CME activity, but particularly in terms of the roles and responsibilities of faculty who might be, and I think, again, this speaks to the issue of intimidation, who might be very used to behaving in a very different way in their own environments. And then work with content. Content's king. You can, or queen, you can use it productively as a kind of boundary to limit hijacking and other kinds of problem scenarios. We've talked about giving feedback. Doing that, it's hard to do and it's hard to hear, but it's manageable if the feedback's personalized and given personally. And we talked about stories, encouraging faculty to use stories. I think, Eve, you mentioned, making your chair your champion, someone who's on side, who supports your goals and can help to identify other sort of true teachers. And then finally, work with quirks or with the quirks of faculty. We're all unique, and faculty are unique, and they have their own educational styles. I think, in CME, we can honor that and work with their quirks as a kind of foundation for supporting them to be really kind of knockout educators. So I think that wraps it up from us. I just want to thank Eve and Robin and Eileen for being fabulous panelists, and also thanks to Scott and Derek for CME Palooza, and thanks to you, the audience. And I'll leave you in Scott's capable hands.
Well, great. Yeah, thank you for everyone who asked such thoughtful questions. I know it's always a good sign of thoughtful questions when you get that 5 to 10 second pause after the question is done, with everybody thinking, well, who's going to chime in on that one first?
Yes.
So for those of you who are watching this live or the archived version, we do have a short survey on the live page to give us a sense of who's watching our broadcasts, and to help us sort of plan for the future. We do have CME Palooza Fall coming up in October. So Derek and I will be hibernating for 2 months before we start planning that one, but it'll be coming up before you know it. And with that, I would like to not only thank this panel, but all the panels for CME Palooza Spring. It's been a busy 2 days, but we've covered a lot of ground as always. And thank you to our audience for tuning in. And hopefully you will keep an eye on us here in the next few months and be back in October for CME Palooza Fall. So thanks, everyone. And on Derek's behalf, go Sixers.
I have no idea.
Thank you, Scott. Thanks, everybody who joined.